I'm Tiffany Strever. I am the trauma program manager here. I have been a nurse for 30 years now, 3 decades. Hard to seem possible that I've been doing it that long. Love it as much today as I did when I graduated from nursing school in 1985. I have been doing emergency trauma nursing for over 20 years. So out of my 30-year career, with the exception of 18 months, I've either been in ED, trauma, or critical care. So clearly I am an adrenaline junkie. Totally admit it. It is not uncommon for me to be in the trauma bay in my heels and suit doing patient care, because you may take me out of the trauma bay, but you're never going to take the ED nurse out of me. In my spare time, I am a lieutenant colonel for the 161st Air National Guard, where I do all the training for our medics and sustainment training for our medics, physicians, and nurses. And then I also sit on the National Board of Directors for the Emergency Nurses Association. So I'm busy, to say the least. And we are going to talk about trauma triage, where EMS and hospital criteria can intersect. So let's play a game. So everybody got a piece of paper, numbered 1 through 4. I want you to answer those 4 questions on that piece of paper. So how much intrusion is there with moderate damage? This is your interpretation. So what would you say moderate damage relates to intrusion? And write it down. We'll just do general intrusion into the vehicle, not into the passenger. So front end damage. What would moderate damage equate to in inches of intrusion? And there's a reason I'm asking these questions. So, okay. And as we get into this, you'll understand why. So then the second question goes, how much intrusion is there with heavy damage? We'll just give you guys a couple minutes to answer these. What does intermediate mean? And then what does delayed mean? And there's reasons I'm asking, and as we get into the lecture, we'll refer back to these at the end of the lecture, and we'll kind of have some discussion on why I've asked these questions. Okay. So we're going to talk about start triage. We're going to talk about the field triage criteria, which you guys practice under every day. We're going to talk about trauma activation criteria internally, which you guys got a handout for that, because again, at the end, we're going to use that. And I'm going to kind of go over the components of our patch phone, which kind of refers to what Willie was talking about when we ask you questions. And then review and practice triaging patient scenarios. So we're going to do some fun stuff. So this is clearly a very interactive lecture, and I have treats. So, all right. So start triage. The start triage is supposed to be used when there's a mass CAS incident. That's where the term intermediate came from. Was the start triage. It's used with the military, it's used in disaster scenarios. Intermediate means I have an issue in airway, breathing, circulation, or disability. If you look at the trauma triage criteria, I could have a GCS of 10 and be activated at a different level than if I have a blood pressure of 70. So using the term intermediate really doesn't provide a lot of information on what we need on our side of the house. Yes? Immediate. So, and if you look at that, so then what does delayed mean? When you're looking at the start triage, delayed means there's a potential for an alteration in those things. So they may have a femur fracture, but they have good pulses. But could that change? Absolutely. So when we're using those terms, it's helpful to be thinking in the same pathway. So as, again, I'm going to refer what to Willie said earlier when he was introducing me. We want to provide the best care and the best resources for that patient once they hit the door. But we don't want to overstress the system. So if I get a call that says I'm expecting 3 immediates, well, are those 3 immediates with airway issues and I need 3 anesthesiologists and I need 3 OR teams? Or are those 3 intermediates that may have, an altered GCS, which is a completely different mode? And clearly I don't do fire, nor do I claim to do fire, but it would be, do I have a trash can fire in the first grade classroom, or do I have a 6-story building on fire? Same principle. I want to make sure that I have the best resources, the appropriate resources for that patient when they hit the door. So when we ask questions, it's not that we're doubting what you guys are doing. It's clearly we want to provide the best care for that patient. And I talk with my hands and I usually move, so being behind this podium is really hard for me. So I'll say that up front. So when we look at this start triage, are they able to walk? Well, if they're able to walk and talk, if they can tell you their name and where they're at and what's going on, they get pushed to the side, they're agreeing, we don't worry about them. Then we start going down. Do they have a spontaneous airway? Yes or no? The first time you hit a no, that triages them to an immediate, and they've got an airway issue. But again, that doesn't tell me on my side of the house, do they need my trauma team, my OR, my MTP, my blood bank, or do they just need my trauma surgeon and x-ray? So quick look, A, no respirations, B, greater than 30, decreased cap refill or radial pulses, can't follow commands. So A, no respirations, you kind of go to that expectant category and bless you. The middle one is a red. Green, can't walk away, and anybody else is a yellow. It kind of makes it simple. If you're not a red and you're not a green or a black, you're a yellow. All right, so in 2001, the American College of Surgeons and the Center for Disease Control got together a huge group of pre-hospital trauma surgeons, epidemiologists, the people that sit on the background and look at every injury that's recorded and what their injury severity score is, which is what we look at. If I roll here's a perfect example. I drive a Yaris, so I drive a little box. If I'm rolling down the freeway and a semi rolls by me and a big gust of wind and I tip on my side, am I a rollover? Theoretically, but what injuries am I going to have? Probably not too much. If I'm rolling down the highway on my motorcycle and that same semi goes by, what are my injuries going to be? My injury severity score is going to go up. So the epidemiologists and the trauma surgeons and the EMS people all got together in this big room and they started looking at mechanisms of injury and the injury severity score and said, we're going to come up with this algorithm for field triage to help send those patients to the right places with the greatest chances of injury. And clearly, once they came out with that in 2011, then EMS across the country and even on our western part of the state here accepted those. So that's what you guys function under, and we're just going to go that quickly. Because what I want you to kind of look at it is, if you look at the field triage criteria and our activation criteria with a few subtle changes, they pretty much mirror each other. So step 1, what's their GCS? Less than 13? Is their blood pressure less than 90? What's their respiratory rate? Anybody breathing less than 10 or greater than 30, they're a problem. Need of ventilatory support. And that's less than 20 in those newborns because we know they breathe faster. So if they have any of those, yes, they should go to a level 1 trauma center. If not, you'll proceed to step 2. Now you'll note at this point, it's not mechanism driven, but however, don't forget the mechanism because again, if I tip over in my Yaris, meh. But if I roll my motorcycle or separate from my motorcycle, which is, I always chuckle, I want to separate from my motorcycle. I don't want to ride underneath my motorcycle between the pavement as it's sliding along and it's ripping off all my skin. So I always kind of laugh about that one. All right, penetrating. So we're into step 2. Is it penetrating? Where's that penetrating trauma? Because if I got shot in the calf, it's probably not big deal. If I got shot in the head, it's a big deal. Chest wall instability. This one can be kind of hard to assess. We're looking for that flail segment where we have multiple ribs that are fractured in multiple places. But with the flail segment, you may not immediately identify it. And why would that be? Yeah, there's cell splitting. You've got muscle spasms that are occurring, so that flailed segment may not show up until a few hours later when they're in the ICU and they're vented. And watching a flail segment with somebody vented is pretty interesting because part goes up and part goes down, and it's totally opposite. 2 or more long bone fractures, so we're talking 2 humeral fractures, 2 femur fractures. And why would we consider this a big deal? What do we know about femur fractures? How much do they bleed? About 1,500 cc. So if I break both my femurs and my pelvis, I can put out 4.5 liters. Am I going to be hypovolemic shock? Absolutely. These people are going to need blood. They're going to need to go to the OR. They may need to go to interventional radiology for embolization of those pelvic veins and arteries. So that's important. Crushed, degloved, and pulseless extremities. When we're talking about a crushed injury, it's not that I dropped a pallet on my foot and I crushed my foot. It's that I was standing at, perfect example, we had this back when I was in Kansas City. We had a gentleman that was at a loading dock and the truck backed up. That's a crush injury, crush between the loading dock and the truck. So again, this is where a little more information is helpful because we can really anticipate A, what injuries they're going to have, but B, again, what resources. Amputations proximal to the ankle and the wrist. And that all relates to loss of blood. You know, if I amputate my pinky, I don't need my trauma surgeon. I need my plastic surgeon and my hand surgeon, and I don't need everybody to show up. Pelvic fractures, always a fun one. Kind of think about what the mechanism is. And we don't like to, if you think there's a pelvic fracture and you've got that crepitus, that's good enough because we don't want a bunch of people pushing on the pelvis. Part of the reason is if you think of your pelvis, it's a ring, and if you fracture it and it's stable, you're going to feel that crepitus. But if you wiggle it a lot, we call it an open book, so think of it as a book. If it's sitting like this when you and I are walking around and we fracture it and we start to move it a lot, it opens up. Then what happens? Then we lacerate those veins and those arteries and we bleed. So this is where your pelvic binder is important too, because you put that pelvic binder on, cinch it up, and it does what? It closes the book, tamponades. Open or depressed skull fractures. Again, if you think they have one, don't do a lot of pushing around because sometimes it's pretty obvious when you start to see the brain start to sift out and stuff like that. Not always really evident. And the paralysis. Clearly paralysis is a problem because they've injured their cord. So again, route to a level 1. If not, we go to step 3, ejection, partial or complete. We know that your risk of injury, if you are ejected, even partially or completely, is a bigger potential for death, either in the immediate or down the road. Example was back in Kansas City, we had a football player, Derek Thomas, who was ejected from his vehicle, and he actually did pass, but not until he got to rehab because of the sequelae related to his injuries. Motorcycle crash greater than 20. Clearly, speed makes a difference. If I'm at the stop sign and I tip over because I wasn't holding my bike up, it's different than if I'm rolling down the freeway and crash. Patient run over or significant impact, again, it's at greater than 20 because if I'm in the parking lot and you bump me with the bumper, it's not going to leave as much of a mark as if I'm crossing the street on Bell and 83rd and get whacked. So again, if yes, go to level 1. If not, go to step 3B. These are where they start to get. So adult greater than 20 feet, children greater than 10 or 2.5 times their height. So the 6-month-old that falls off the counter, whacks their head. Intrusion, greater than 18 inches into any portion of the vehicle or 12 inches on the side of the passenger. What do we know about vehicles today? They are made to crush. But that being said, if I'm the passenger and I'm T-boned or get lateral impact and it goes 12 inches into my side, I'm going to be significantly injured. Death in the same compartment. Why is that important? The force isn't enough to kill somebody in that vehicle. Chances are everybody else is going to be injured as well. Auto versus ped or auto versus bike. Less than 20 miles an hour, you may have some injury just because of the mechanism. Not run over or thrown. So if I'm hit at 15, but they don't run over me, they just knock me down, these probably can go to a level 3 potentially because they're less of a chance. But again, it depends on a lot of other things. What's their vital signs? If I fall 20 feet onto concrete or 20 feet into a mud puddle, different injuries are going to occur. Step 4, older adults. In the trauma world, you are considered an older adult at the age of 55, which does not make me very happy as I edge ever closer to that age. So just because we know their risk of injury and death increases, the number one cause of death after age 65 from injury-related death is actually falls. So falling when you're older creates a problem for a lot of reasons. One, they're all on anticoagulants, right? So we fall down, even if it's a ground level fall, we hit our head, we get a bleed, we die. The other interesting thing is that we talk about blood pressure in the older population. So if you're over 65, you can be considered hypotensive if your systolic is less than 110. Reason being, as we age, we naturally have some hardening of the arteries that occurs, so our blood pressure naturally goes up. The other piece to that is a lot of these people are on medications that are not going to alter their heart rate or their blood pressure. So if we see an older person that actually falls and has a blood pressure that is 100, it should elevate our level of suspicion that they may potentially be in shock just because of the compensatory mechanism, the natural changes that occur. So in this population, that ground level fall, which is one of the low impact mechanisms we look at, may result in severe injury. This is the patients that fell down 3 steps, and while if it's you or me, it's like no big deal, well, these patients could be injured. Kiddos, they should be preferentially routed to a pediatric capable trauma center. State of Arizona is really good. One of the initiatives they have now is pediatric capable designated EDs, which means their staff has extra training to care for children and stuff like that. But what are our 2 level 1 pediatric centers in Arizona or in Phoenix? Children's and Maricopa. So what age are pediatric trauma patients? 0 to 14. Once you hit your 15th birthday, you are considered an adult by the trauma world, which again is really weird, but it is what it is. So if I have the 6-year-old that's on the monkey bars, which may or may not be 2.5 times their height, and they fall off and they have a fracture or an obvious sign of injury, it's very likely that you should go to that pediatric routed, or better yet, let's say this. We have a motor vehicle crash, we have a 15-year-old, we have a 25-year-old driver, we have a 6-year-old. And there was also an 80-year-old, and the impact of the crash killed the 80-year-old. How many of those, so now we still have a 25-year-old, a 15-year-old, and a 16-year-old. How many should go to an adult facility? 2. How many should be routed to a pediatric facility? 1. Okay. Does that make sense? Okay. Right, and that's why they kind of cut it off at 15, because you think of how many of our little old ladies weigh 90 pounds. I mean, my sons, when they were teenagers, my one son was 6'4" at 13. Theoretically, he needed to go, but yeah, he's big kid, but still a pediatric. So yeah, sometimes it's one of those, and that's where you may look at him and you're like, oh, well, he's, 16, 17, and that's okay. I mean, if we could say that this was black and white and there was no gray, we'd have a great day in the trauma world, but it's not. And the other piece of the triage with the kiddos is, if they are unstable, absolutely go to your closest trauma center, because the reality is that closest trauma center can always stabilize and ship as appropriate. The other thing, what do we know about kids? They look great, they look great, they look great, they die. And luckily for me, I've always worked with some really great, up until working here, I've always worked in adult pediatric centers, both the trauma centers I worked at in Kansas City, and then I was actually a trauma program manager over at Maricopa for 4 years. So I like kids, which is kind of unusual because a lot of people don't like kids because they're scary. But you're right, they look great, and it's because they compensate so well. They'll compensate for 25% of their circulating volume being gone before you'll see a change. So that's, and the first thing we always think about when we're looking at people and determining if they're in shock, what do we look at? Heart rate and blood pressure, right? Well, if I can compensate for 25% of my circulating volume being gone before I have an alteration in my blood pressure, not a good indicator. What else do kids do that are going to increase their heart rate? Scream, cry, because they're scared. So that alters that. So what's your best indicator of shock in a pediatric patient? Cap refill. Anything over 3, that kid's in trouble. Because cap refill is one of the few things that is specific to assessing shock in the pediatric patient. Not good in older people because we develop peripheral vascular disease, there's all kinds of things, but your cap refill in your pediatric patient is going to be absolutely critical to assessing your shock status, because so many other things can affect it. And the first thing those kiddos do is they shut down their periphery and shunt it to the center. So checking their cap refill right off the bat will give you a good indicator what their status is. Don't forget to check their heart rate and their blood pressure and stuff. But a lot of us, I don't remember always the formula for what normal blood pressure is or whatever, and unless you have that little cheat sheet in your car, in your hand. Thank you, Willie. Just cap refill will give you a lot. And then what's their mentation? With pediatric patients, if they let you guys come up and start sticking them with monitors and IVs and stuff, that is a bad sign. So when it comes to kids, if they're stable, they meet your field triage criteria, try and go to a level 1, pediatric appropriate. If not, stop and we'll do what we can do and we'll take it from there. One of the other considerations in this group is the anticoagulants and the bleeding disorder. We talked a little bit about that, those populations. And what we know now about all these anticoagulants, a lot of them aren't reversible. We've got things, so now instead of, everybody's on Coumadin, they're on Plavix, and they're on all these other ones. And so are we going to give them PCC? Are we going to give them FFP or a variety of other things? Burns. As with the pediatric patient, if it's strictly a burn, turf them to the burn center. If they have other mechanisms, so motor vehicle crash, or a motorcycle crash, they've got a lot of road rash, but they've got a broken femur, they've got a broken pelvis, they've got a head bleed. Take them to the trauma center, the closest trauma center. We'll fix their trauma issues, because in the reality of it, the burn can wait versus I'm bleeding to death because I have a pelvic fracture. Pregnancy greater than 20 weeks. Just because I'm pregnant and I'm in a car crash does not make me a trauma patient. They need to have a special consideration because there are pathophysiological things that go on that change us and whatever. But, was it a motor vehicle crash at a high rate of speed? There's 18 inches of intrusion, and she's complaining of abdominal pain. Ding, 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 patient needs to go to a trauma center. The interesting thing is that there's two big sequelae we see with motor vehicle crashes, especially in the late third trimester, and that is premature labor. That's the number one complication we see. But we also see placental abruption. And what makes that interesting is most trauma centers will monitor the pregnant patient late third trimester, especially after a motor vehicle crash, for 24 hours. Usually a placenta abruption doesn't occur until about 48 to 72 hours, so it's very much of a delayed onset. So there's a lot of literature going on and research to determine if these patients need to be kept a little longer. And then it always comes down to EMS judgment. I mean, what do you think? Sometimes we see that car that doesn't look that bad, or that fall didn't seem that bad, but something just doesn't smell right. And usually if it doesn't smell right, it's probably not right. When in doubt, transport to a level 1, and of course, pediatric trauma, going to that pediatric capable facility first if at all possible. All right, so your guys' criteria. So where do our criteria and your criteria meet? This is the next step. Internal triage does start with the CDC guidelines. And if you look at your sheet, there's ACS mandated specific criteria. That's the American College of Surgeons. So to be a trauma center in the state of Arizona, if you're a 1, 2, or 3, you have to have the American College of Surgeons come in and spend 2 days of grueling chart review and a variety of other things. And then they tell you, yes, you are, or no, you aren't. And if you're not, you've got to fix these things. So if you look, one, like right at the top of the list, confirmed blood pressure less of 90 anytime in adults. Anytime. And when we get into this a little further, we'll talk about why that's important, or age-specific hypotension in children. That is a mandated criteria by the college. It does reflect, and part of this comes out from the fact that the college sat with the CD and the EMS people and did this. Create a tiered response. So everybody doesn't need the kitchen sink when they come in. Somebody can get, just lab, x-ray, trauma nurses, and maybe just the ED physician, and then as you get sicker, you get more. It's a fluid system that is under frequent review and revision. So one of the things we're looking at right now is, are we going to reevaluate our rollover criteria? Looking at how many rollers have we had, what was the rate of speed, what were the injuries, did the patient go home? It kind of goes, did I tip on my side or did I roll 6 times into a ditch? And that's where we use the registry data. So every patient that comes into the hospital as an activation or is admitted with an injury goes into a registry. In the simple patient, I fell down 20 feet, I have no injuries, and I go home, there's a minimum of 400 data points that is captured on that patient. That's everybody. So now you take that patient that fell 40 feet onto concrete, broke everything, had multiple procedures. You can see that exponent, but it's great because my registrars who happen to be sitting in the back, I'll go in and say, I need a report for every motor vehicle crash with MRN number that was over 70 miles an hour, that was a rollover, that had an ISS of greater than 16. Boom, they write the report. I can look at the data and determine. So right now, we're looking at some different things. A couple of the things that we found interesting here, moving to the West Valley, golf cart injuries. We are clearly in the side of town where we have a lot of people that like to drive their golf carts and not always sober, I've noticed. But we're finding that these people have really high injury severity scores, and some of our deaths have actually been golf cart injuries. So because our data showed us that these people just didn't need to go to the ED, we have put them in our triage criteria. So we will activate them internally, even though it's not on the CDC criteria. But if you tell me a golf cart got hit by a Chevy truck, which we've had, and the patient was ejected, they're going to get it. And then the other one that's kind of unique to Arizona, sort of, is kicked and bucked off a horse, because we see significant injuries with this population as well. Yeah, we're going to my Yaris is going to look like a tin can, and I have several EMS friends that have said if I'm ever in a crash in my Yaris, they'll just plant me in the Yaris. Yeah, actually we do, and when I look at that report, I'll get the basics of my rollover crashes, and then I'll start to deep dive it and say, what was the vehicle involved, if I have that information. If I don't, I do the best I can, but yeah. So, and yeah, so So if you didn't hear that, one of the questions was, does vehicle make a difference in the rollover? And are we looking at that? And with the ICD-10, which is coming October 1st, a lot more data is going to be requested. So the more complete you can be on your run sheets, the better off. So a 2013 Yaris hit by a 2014 Chevy half-ton truck at the intersection of Bell and whatever, at a rate of 50 miles an hour and yada yada. So it just helps us, and definitely helps when determining who needs to go where, because it's much easier for you guys to go 20 minutes than 45 minutes, right? Right. Yeah. Right. So yeah, augmenting your sheets to do whatever. Yep. Yeah. So if you look at our activation criteria, which you also have in front of you, we have an older adult, greater than 55, low impact mechanism, example, ground level fall, signs of injury. So just because I fell to my knees doesn't mean I have an injury. Systolic less than 110. Are they on anticoagulants? We will most likely activate as the C, which means you get trauma nurse from both the ED and the ICU. You get the ED physician, you get lab and radiology, because a lot of these patients are going to end up with head bleeds and in the ICU. And then we do get a lot of transfers, so this is also where our emergency physicians can determine that perhaps that patient coming from a different facility, whatever level, or a non-leveled facility, may need a few more X-rays a little bit quicker than just the typical emergency department patient, and they will activate them just for resource utilization. So moving up to B. B is a little more intense. You get lab, you get radiology, you get the ICU and the ED trauma nurses, you get the ED physician, you get the trauma program manager sometimes, you get the trauma surgeon and the trauma mid-level. 24/7, we have a trauma surgeon and a mid-level, whether it be our nurse practitioner or our PA is in-house. So they sleep in-house and they're in-house. So with our Bs, it's our falls greater than 20 feet with 1 story equals 10 feet. Children, 10 feet or 2 to 3 times their height. This is where the intrusion comes important. Was it 12 inches into the occupant side or 18 inches on any site? Ejection from an automobile, death in the same passenger. If you tell me I have moderate damage, how much intrusion is that? Moderate for me could mean a whole lot different than moderate for you. That's why, and I don't, getting the tape measure isn't necessary, but this is 12 inches, give or take. Death in that same compartment, again, are auto pedestrians. So you'll start to see that a lot of these are on that CDC, motorcycle crash, Glasgow coma score. Show what is their GCS. Any vehicle, a rollover, and we're looking into this because, again, we kind of have to define it a little bit. Kicker bucked off a horse, our golf cart, and then our physician discretion for those transfers in. Blood pressure less than 90. Give us your lowest blood pressure. Because if you arrive on scene, you've got an open pelvic fracture and the pressure is 80, and you give them a liter of crystalloid, and now you're calling in and you've got a pressure of 110. So give us the lowest blood pressure. Because if it was 70, I want to know it's 70 because I need my trauma surgeon there. So if you are an A, you get everybody that came to the B, but you also get blood bank, and OR. They're standing in my trauma bay so that and anesthesia, because these people are going to most likely go to the OR. Blood pressure less than 90, you're bleeding. GCS less than 10, you probably need to be intubated and you may have a bleed. Respiratory rate, definitely need to be intubated or protect that airway. All penetrating injury to the head, neck, torso, and extremities proximal to the elbow. This comes in, if I shoot my calf, I probably don't need the trauma surgeon, but if I shoot myself in the femur, I do, and I need to go practice with my gun a little bit more. Chest wall instability or deformity, and then our long bone fractures. You'll notice that the A list is much more encompassing: crushed to gloved, amputation proximal, pelvic fractures, skull fractures, paralysis, the combination burn trauma. Right now it says pediatric patients 0 to 14. We are revising that because just because you are a pediatric patient that happens to be that 13-year-old that's 6'5" and comes in doesn't necessarily mean he needs. So we're going to start activating those pediatrics that come in either walking in or how, accidentally end up here, appropriate to mechanism. And we're looking at our pregnancy again as well, because just because you're pregnant doesn't mean you need everybody. But we do, if you are pregnant and you come in, you will get the OB and the OB nurse and the ultrasound tech to do a bedside ultrasound quickly. Transfers that are unstable, and you'll notice this is specific too. This kind of goes back. So we said that those over 55 with the low mechanism impact, the ground level falls, were a C, unless your blood pressure is less than 90. Because what do we know? We know if your blood pressure is less than 110, you might have an issue. So if it's less than 90, you're in shock, and we need to get more resources available for your care. So when we look at our patch phone, we talk about things, and this is stuff you guys give us: age, mechanism, vitals, injuries, treatment. More is better, but concise. I have a 55-year-old, motor vehicle crash, 12 inches to the passenger side, death in the same compartment, blood pressure, worst blood pressure was 70, heart rate of 120, IV with 500 bolus given. I'll be there in 15 minutes. What is that patient? That patient is an A by my criteria. How long did that take? 30 seconds. So, for treats, we're going to do, the one thing I didn't talk about and I want to talk about, when you guys, sometimes we'll get that call from alarm room that we're bringing 3 immediates. We're going to meet you at the door. We're going to let the trauma surgeon know, but we're going to meet you at the door and triage at the door, because we don't want to utilize all of our resources for something that may not meet it. And we understand that if you come on a crash and there's 5 cars and there's 15 patients, we got it. If you can take a couple minutes and patch, that would be great. but we'll work with it. So, unknown age female motorcyclist hit by a car at 25 miles an hour, not wearing a helmet. Vital signs are there. Open femur fracture, IV, and spinal mobilization restrictions. If you look at your sheet in front of you, we know that she needs to be triaged to a trauma center, correct? So our integral triage would make her a what? B. Who said B? Her vitals are stable. Her blood pressure is stable. She only has possible of one long bone fracture. Her GCS is not less than 10. She meets B criteria because of the rate of speed that the motorcyclist was hit. 75-year-old ground level fall. Visible head laceration, uncontrolled bleeding, unbled thinners, blood pressure 110, heart rate 65, which means she's probably on, beta blockers. Respirations at 26, GCS at 13. This is a tricky one. So this would be a C. And the reason is it's a low mechanism injury in that elderly population, and the only time we transfer them up is if their blood pressure is less than 90. Make sense? But they still need CT because this is going to have the subdural, the subarachnoid, and they're going to go to the ICU and maybe do okay. 16-year-old female, motor vehicle crash, ejected high rate of speed. What's a high rate of speed? 55, 65, 75, 95. Intrusion greater than 12 inches. Intrusion where? So, like I said, more is better. Intrusion 12 inches into the engine compartment, meh, big deal. 12 inches into the passenger compartment, big deal. So, what would this patient be? There is one key here that will tell you what it is. C category is only for age over 55 with low mechanism injury, so it's not a C. It's a B, and why is it a B? Ejected. I don't know that I can reach you. Whoop, no. All right. 20-year-old motorcycle crash, no helmet, almost stopped less than 20 miles an hour. Occipital laceration, vitals are stable. Who said ER? I'm not going to throw it to you, but see me afterwards, because I know I will make it back there. 15-year-old with a 15-foot fall, blood pressure 90, heart rate 135, respirations 36, GCS at 12, femur fracture, and an unstable pelvis. A, absolutely. Not only that, am I happy with a blood pressure of 90 in a 15-year-old? Oh no, this guy is bleeding. He'll probably go to interventional radiology to get the pelvis embolized and then go on to have his femur and stabilization. So definitely an A. 16-year-old found hanging in the closet, being bagged. Pulse is 35. We gave some atropine. Pupils are pinpoint. Shush. All right. Hangings, drownings, and asphyxiations are not trauma patients. So these get dicey. Now, there's always caveats to that. You hung yourself from the old oak tree in the backyard, and it was 35 up, and you picked a bad branch, and it broke, and now you have a big old lack and stuff like that. So there's always exceptions to the rule, right? I always said if it was black and white, it would be easy, but it's not. So, but yes, in the scheme of things, drownings and hangings are not traumas. 29-year-old transferred from another facility, multiple lacerations. Tourniquet required to control the bleeding, intubated in another facility. GCS is clearly at 3. This would be an A. Right. Yeah. Stab wound to the abdomen. Vitals 84 over 40. I can stop. Actually, I can stop with the stab to the abdomen. That would be your high level. That would be your A. 21-year-old female, motor vehicle crash, moderate damage to the passenger side, medical unknown, vitals are stable. Sign of refusal. Do you guys press hard 5 copies? Yeah, with this, it's probably going to go to the ED because I don't have enough information to determine whether I need to activate my trauma team. 35-year-old struck by a pickup at a low rate of speed. Truck rolled onto its side. Slow to respond, complains of head pain, but still a GCS of 15. Vitals are stable, ankle deformity. Yeah, right? What was she in? Exactly. Rolled on its side, though? Is that really a rollover? Was there any intrusion other than maybe on the side she fell on? So, again, this is going to be one of those that we'll probably say, we'll see you, and then we'll make our decision. 25-year-old male riding a bike hit by another vehicle at 15 miles an hour. No helmet, but they hit their head on the curb, and they've got a GCS of 6. It's going to be our high level because of our GCS. 64-year-old ATV crash. Multiple broken arm, broken shoulder, abrasions, flank pain, knee pain. ATV crash would be a B. Alarm room call. Motor vehicle crash, 2 immediates, no vital signs, ETA 15 minutes. See you when you get here, exactly. Now, I will tell you there is a caveat to that. If I get an alarm room call that says there's a trauma code, I'm activating the team because that's a completely different scenario. So we have 2 patches here. Patch 1, number 1, 25-year-old male involved in motor vehicle crash, no intrusion into the passenger compartment, 10 inches intrusion to the rear end, vital stable. ER patient. Alarm room, second call, unit XYZ en route with a second patient from the motor vehicle crash, full arrest, ETA 5 minutes. Going to activate that one, absolutely. 14-year-old fell 20 feet, complaining of back, left arm, and neck pain and obvious left arm deformity. Urgent care. Well, 20 feet would be a fall that would activate criteria even in an adult, but we're a 14-year-old, so we are going to children's. 85-year-old golf cart crash at 25 miles an hour into a cactus. Some of these are actually true patch phones from here, so cactus are not fun to run into. Vitals are stable. GCS is off a little bit. Laceration to the nose. IV and C collar. They did give a bolus, so the blood pressure was a little better. But based on this, golf cart greater than 25 would be a B. And he actually was sick. 28-year-old female, 24 hours ago, shot in the kneecap, transferred from a sister facility. Pulse is present in the foot. So now this is one of those, is the knee proximal or distal? This was probably seen in the ED because we have pulses and they're stable and it's 24 hours out. We call it the I've passed the will to live test. It's like patient rolled their vehicle into the canal, got out of the vehicle, swam to the edge, walked home, took a shower, and came in 8 hours later. Yeah, doesn't need to be an act. If you can do all that after rolling your car into canal, you're good to go. Yeah, went home and metabolized, exactly. 75-year-old male involved in a rollover with death in the compartment. BP 92, GCS of 12, open femur fracture. You know, he technically is a B, but this is one of those patients I would look very closely at, because if he's 75 and there was a death in the compartment and his pressure's 92, I would want to make sure he was okay. Motor vehicle crash, rollover 60 miles an hour, 8 inches of intrusion in the endon block, but she's 30 weeks pregnant, so we would activate her because it's definitely appropriate at that point. Kicked by a horse, we know it's a B. 4-year-old male unrestrained passenger in a motor vehicle crash, CPR in progress, femur fracture, open laceration to the occiput, IO, epi, bolus of normal saline. What are you guys going to do? Just going to stop. We're going to be in the trauma room and on the phone to the nearest helicopter. 35-year-old, fire pit blew up in the face, burns to the face, laceration to the eyebrow with metal, patient presented at triage. Now this is going to be one of those that these walked in, so this is also a lecture that I do for the staff here. So this one presented to triage. The concern is what with this patient? Burns to the face and that airway, so we would activate, secure the airway, and get him out of Dodge. 92-year-old slipped down one step. Blood pressure's 82. Large avulsion laceration to the scalp. They got a bolus of 500 cc's and his blood pressure's still 82. We're going to activate him at our highest level because even though it is a low mechanism injury, his age and his blood pressure bump him up. So you can't see this very well, but our patch sheet actually contains our criteria. So when you're on the phone and you're giving us the information, this is what the nurses are going to say, may prompt those extra couple of questions. So back to our questions. How much intrusion is moderate? Less than 18. And then how much is heavy? Then we talked about what intermediate and delayed meant. So really, it's trying to get everybody on the same page and doing what's best for the patient and the utilization of the resources. We're not trying to be grumpy nurses when we ask you a couple more questions. Sometimes we are. We really, truly are trying to do the best utilization of resources, not only your time and your effort, but what that patient needs for the overall care of that patient. Is there any questions? Right, like what I said in the beginning. Yeah. Yeah, because and I'm lucky because Willie and I he gets to listen to me on a daily basis. But yeah, what I want is probably a lot different. Like I said, I have a 35-year-old motor vehicle crash, 12 inches of intrusion into the driver's side. She's complaining of left-sided chest pain. Her blood pressure's 86. Boom, done. And I'm going to be there in 10. Okay. That would be interesting. Okay. Right. Right. We can work on that. We can do something like that and get it out to you guys. All right. Any other questions? All right. Thanks, guys.